fair to say that immunology is really coming of age in multiple myeloma, and we've waited a long time for this. I think in conceptualizing CAR T cells, it's useful to look at immunotherapy as two broad classes. One can give antibody treatment, but CAR T cells involve giving re-engineered immune cells, T cells, back to a patient. There are really three main trials that have looked at CAR T cells in myeloma, and each of them has its advantages and disadvantages. The one that we're familiar with, particularly at my institution, is the BB2121, which was recently reported at this meeting and also at ASCO. In this trial, the patients that were treated were very advanced and really only had the option of palliative approaches if they did not proceed with CAR T cell treatment. The patients that were treated on the BB2121 trial had received, depending on the cohort, 7 or 8 prior lines of treatment. And they were by and large penta-drug exposed. That means they had received bortezomib, lenalidomide, pomalidomide, carfilzomib, and daratumumab, the monoclonal antibody with good efficacy in advanced disease. And a significant proportion were actually refractory to all these drugs. So really there were no standard or accepted or regimens that would have a reasonable expectation of efficacy in the patients that were treated in this initial CAR T cell experience. With BB2121, there was a dose response experience, so that patients who had over 150 times 10 to the 6 CAR T cells infused had an excellent response rate on the order of 90% or so. And depending on the depth of response that was achieved, there was quite an exciting progression-free survival that for those in the expansion group, it was almost a year of progression-free survival. And if we looked at the patients who were MRD negative, achieving minimally, really no detectable myeloma, they had a median progression-free survival of a year and a half, these are unprecedented findings in patients who have been exposed to all the effective drug classes. We're learning about how to give CAR T cells because there are these unique toxicities of cytokine release syndrome, which fortunately has an antidote if needed in treating it with an anti-interleukin-6 antibody called TOSI as a nickname. And the other toxicity is neurotoxicity, which, if severe, needs to be treated with steroids. I think one of the attractive aspects of BB2121, at least preliminarily, it appears that these toxicities are not as severe in some other CAR T cell trials. So of course there'll be a learning curve as institutions start to adopt CAR T cell treatment for different cancers, but a great deal of information was learned from the BB2121 trial on management and identification of groups of patients that could be at higher risk, specifically higher baseline ferritin levels. In myeloma, CAR T cells offer a quantum leap forward in terms of exploiting cellular therapy and immunotherapy in a very specific way. I think there are lots of directions this could take. Of course, defining the best patient groups, we don't anticipate that this will be a treatment that should be reserved for virtually end-stage patients. So there's great interest in moving it up earlier in the treatment course. Also, myeloma is a very sneaky disease, and there's been the thought that maybe one would consider CAR T cells with different specificities besides BCMA. Maybe you need T cells directed against more than one antigen on the myeloma cells. There are ways that are going to be explored to abrogate toxicity. Maybe one needs a way to be able to turn off the CAR T cell if it gets out of hand. And I think some groups are exploring, do you need to dial in the different types of CAR T cells in for instance, the proportion that are CD4 or CD8 positive. So I think we're really just at the cusp of a new generation of therapeutic options based on CAR T cells in myeloma.